A synoptic pathology report for renal cell carcinoma. Welcome to the Everything Surgery podcast, where we delve into the intricacies of surgical pathology. Today, we present a comprehensive, checklist-style pathology report for renal cell carcinoma, formatted according to international standards from the College of American Pathologists and the International Collaboration on Cancer Reporting. Specimen information. The specimen received for analysis may be a radical nephrectomy, partial nephrectomy, or, in certain cases, a core needle biopsy. The laterality of the specimen is noted as either right or left, and the size is recorded in 3 dimensions. The precise site of the tumor within the kidney is identified, whether it be the upper pole, mid-portion, lower pole, renal pelvis, or the region adjacent to the hilum. Tumor focalities is determined, distinguishing between a single focus or multiple foci, and the greatest dimension of the tumor is measured in centimeters. Histologic type. The World Health Organization classification from 2022 guides the identification of histologic type. The most common subtypes include clear cell renal cell carcinoma, papillary renal cell carcinoma, further categorized as type 1 or type 2, and chromophobe renal cell carcinoma. Other rare types such as collecting duct carcinoma, renal medullary carcinoma, tumors associated with microphthalmia transcription factor family translocations, and fumarate hydratase deficient renal cell carcinoma may also be reported. In some cases, the tumor may remain unclassified. Histologic grade for the major subtypes, namely clear cell, papillary, and chromophobe renal cell carcinoma. The nucleolar grade is assessed using the International Society of Urological Pathology criteria. Grade 1 is characterized by absent or inconspicuous nucleoli at high magnification. Grade 2 reveals nucleoli that are evident at very high magnification but not at lower magnifications. Grade 3 is marked by nucleoli that are easily observed at lower magnification, while Grade 4 denotes extreme nuclear pleomorphism or the presence of sarcomatoid or rhabdoid differentiation. The presence or absence of sarcomatoid and rhabdoid features is documented, along with the percentage of tumor involved. Pathologic staging. Pathologic staging follows the 8th edition of the American Joint Committee on Cancer Guidelines. The primary tumor is categorized by size and extent of invasion. For example, a tumor limited to the kidney and measuring 4 cm or less is designated as stage 1. Tumors extending beyond these dimensions or infiltrating the renal vein, perinephric fat, pelvic-calyceal system, or vena cava are staged accordingly, with the most advanced category indicating invasion beyond Gerotis fascia or into the adrenal gland. Regional lymph node involvement is noted, distinguishing between absence, presence, or inability to assess lymph nodes. Distant metastasis is typically determined through clinical or radiological means, with absence or presence clearly stated. Margins. Margin status is critical, especially in partial nephrectomy specimens. The renal parenchymal margin may be uninvolved or involved by invasive or in situ carcinoma. Perinephric fat and renal vein or ureteric margins are similarly evaluated for tumor involvement. These findings guide subsequent management, as a positive margin may necessitate closer surveillance or additional intervention. Other pathologic findings. Additional features are meticulously documented. Tumor necrosis may be absent or present on macroscopic or microscopic examination. Lymphovascular invasion is recorded when identified, specifying whether it is intratumoral or peritumoral. Invasion of the renal sinus, perinephric fat, pelvic-calyceal system, and microvasculature is noted, including the specific vessels affected. Non-neoplastic changes in the kidney, such as nephrosclerosis, glomerulonephritis, or diabetic nephropathy, are also reported. Other lesions, including angiomyolipoma, oncocytoma, or cysts, are described. The adrenal gland status is specified as uninvolved, involved by direct extension, or containing a separate metastatic deposit. Additional studies were performed. Immunohistochemistry provides diagnostic clarity. For instance, clear cell renal cell carcinoma typically shows positive carbonic anhydrase 9 and negative cytokeratin 7. Papillary renal cell carcinoma demonstrates positive cytokeratin 7 and alpha-methylacylcoa racemase. Chromophobe renal cell carcinoma reveals positive cytokeratin 7 and KIT. Molecular studies, such as fumarate hydratase immunohistochemistry or fluorescence in situ hybridization for gene rearrangements, may be included to further subtype the tumor. Pathologic stage group. The overall stage grouping, as defined by the 8th edition of the American Joint Committee on Cancer, ranges from stage 1 through 4. Stage 1 includes a tumor limited to the kidney without nodal involvement or distant metastasis. Stage 2 encompasses larger tumors still confined to the kidney. Stage 3 includes tumors with regional lymph node involvement or extension beyond the kidney, while Stage 4 reflects the most advanced disease, either by direct extension or distant spread. Commentary. This optional section allows the pathologist to provide diagnostic nuances, prognostic correlations, or additional findings not captured elsewhere in the report. Such commentary may highlight unusual features, discuss implications for clinical management, or emphasize adverse prognostic indicators. Signature and documentation. The report concludes with the signature of the pathologist and the date of completion. Keynotes for clinical use. The nucleolar grade and pathologic stage are paramount, serving as the most critical prognostic factors that guide patient management. The histologic type determines therapeutic options. Clear cell renal cell carcinoma responds well to vascular endothelial growth factor targeted therapies and immunotherapies, while other types may require alternative, trial-based regimens. Adverse features such as sarcomatoid or rhabdoid differentiation, tumor necrosis, and lymphovascular invasion indicate more aggressive disease and poorer prognosis. Margin status is especially crucial in partial nephrectomy, as a positive margin may necessitate ongoing surveillance or further intervention. The use of a structured, checklist-style report minimizes ambiguity and ensures that all essential data are captured for treatment planning, staging, and prognosis. This synoptic approach is often complemented by a brief narrative description detailing the gross and microscopic appearance of the tumor. Thank you for joining us on the Everything Surgery podcast. If you appreciate our content, please like, share, and subscribe for more expert discussions on surgical pathology and beyond. Until next time, keep dissecting the extraordinary.